Welcome to the Catalyst Podcast, brought to you by Chestnut Health Systems. I am your host, Charles Epstein. Today, I'm joined by Alex Dopp, Senior Behavioral Social Scientist with RAND. Alex is an implementation scientist and child clinical psychologist who studies the use of research evidence and related policy implications for improving youth mental health services. He has a rare dual expertise in mental health services and economic evaluation, which has allowed him to conduct research on quote-unquote upstream influences, such as financial strategies and the like, and quote-unquote downstream outcomes, i.e. economic impact of the implementation of evidence-based mental health treatments. Alex joins me today from his office in Los Angeles, California. Alex, hey, how are you?
Doing well. Thanks for having me.
Delighted that you're able to make the time. We had a really good pre-production call. It's a great conversation, so I'm looking forward to this. So let me ask you straight away. It's a question I usually ask guests who come on who have very interesting backgrounds. What first drew you into implementation science and child clinical psychology, and how did you end up focusing on youth mental health services?
Yeah, I would say I really started with youth. Some of the earliest jobs that I had were things like working at a summer camp. And I kept getting this feedback of, you're really good with kids, you're really good with the parents or caregivers. Like you sort of seem to understand what people need and how to sort of like connect with them and support with them. And I think I was sort of it felt intuitive to me to think about things in a developmental lens, like sort of where is this person at in the process of their development and, what they're trying to get out of this experience. And so it started with summer camp, and I majored in psychology in undergrad and started working in more clinical settings. As I got exposed to that, I started noticing these disconnects between what I was being taught in class about research, about what we knew about treatment, what did and didn't help people when it came to therapy or other sorts of mental health services. And then I went out into the community and what I saw was really different. And I think I was just curious about that. I wasn't trying to take this sort of snooty academic perspective of, oh, well, why are these people out in the community not doing these things, even though we know that they work? It was more, that's so interesting. What goes into that? How do they decide that this is the approach that they want to take, as opposed to what I was hearing about in class? So that was kind of the questions that I was curious about that led me to apply to a PhD program in clinical psychology and try to better understand. Let me become both the producer of this evidence and get clinical training as someone who would go and implement and deliver these treatments and see if I can understand how to bridge that gap. And the field of implementation science was really created to try to bridge this research to practice gap, which is a pernicious issue that you run into anytime you're trying to do research to inform practice and policy. And it's really hard to do it well. Even studying implementation, we have gaps between how we study it and what the practical implications would be for doing implementation in the real world. But yeah, those are, some of the experiences I was having along the way that were kind of giving me an indication. This is where you could be useful. This is where you could be in service to people and conduct research that would have some real world value for folks.
Great. I do want to get into your work at RAND. Just a couple quick questions. For our listeners who are not familiar with implementation science, if you would give us a handy definition of what that is.
Yes. So you can think about implementing anything. The field of implementation science is really how do you use things from research evidence in policy and practice? But we implement things all the time, every day. When I've taught implementation science in the class in the past, we use this exercise from getting to outcomes, which is a sort of strategy or training program that you can go through to learn how to implement things better. And the exercise we use is, how do you plan and implement going on a vacation? Or you can pick some other life goal if going on a vacation isn't part of your plans. But basically, the idea is, how do you understand what the needs are and how some sort of evidence-based or best practice, however you want to identify it, how can it fit those needs, and how can you actually set it up within a practice environment, whether that's one specific setting, at a system level, at a policy level. How do you get that set up to where it can be used in actual services? And how can it go have a life beyond the tightly controlled settings in which a lot of research happens?
So the next step, once you set this up, is to see how it survives contact with reality.
Exactly. And how can we do a better job of promoting, supporting folks in navigating that gap with these people who are working at that liminal space between research and practice, or between research and policy. They're often using active strategies to understand what the research evidence says and translate it into the setting where they're working. So some of it can be just put your hands up and say, well, what happens in the real world? And the other part of it can be, what are folks doing? The implementers who are supporting the process, they're facilitators, they're model experts, they're champions on the ground in the setting who are implementing. What are they doing actively to bridge this gap?
Excellent. So if you would describe your work at RAND. And by the way, one of the things we spoke about in our pre-production call was the idea in the public imagination of what RAND is. To me, and I think to a lot of people, or some people, it's almost synonymous with a large, sprawling, faceless organization that's in all of these sectors. It's a global company. If you would, disabuse our listeners of some of that mythology. And number two, describe some of your work at RAND.
Yes, I can certainly relate to that as someone who didn't know much about RAND beyond sort of what's in the public consciousness before I came to work here. And I really ended up applying by accident because my husband had a career opportunity in the Los Angeles area. So the first thing that I always want to make sure is very clear to people is that RAND is a nonprofit, nonpartisan policy research institute. Our origins are in military and defense federal contractor work. And so we're often grouped in with a wide variety of quote unquote think tanks. And some of those think tanks have very explicit political leanings and others do not. And RAND is explicitly nonpartisan and objective. Part of that is that our ethos is very much, we provide the evidence to inform decision makers. We don't tell people what they should think or how they should do. So that sort of allowed some of this mythos about what RAND is to persist, because we're not out there going, hey, this is exactly who we are and how you should think about us. That's just not really how we approach dissemination to any audience, including the general public. So over the years, RAND has really expanded to do work that is policy relevant in any sector. And so as someone who is a clinical psychologist who works at RAND and didn't have formal background in policy, I wasn't sure applying here necessarily, would it be a good fit for me? What would I contribute to an organization like this? But what I've learned in applying and since working here is that there's such diversity in the work that we do. We work with a range of different funders, and that can be grants, it can be contracts where you're working really closely with the funder to manage the entire research process. And the focus is really on solving thorny problems within society that require a multidisciplinary approach, which I really appreciate. I have this background that you alluded to as a clinical psychologist who's been pulling methods from other fields. And that really requires collaborating with people who are not psychologists. And so it was a very natural fit to me to come to a place where sometimes I have to go look up what my colleague's degree is in because I know what their skill set is and I know what we've collaborated on, but I'm like, what did they actually go to graduate school for? Sometimes I forget because it's all just sort of based on, okay, who are the right people to put on this team, who are going to have sort of complementary perspectives, backgrounds, and skill sets so that we can collectively come together around challenging problems and try to solve them. And that includes external partners too. So I've done quite a lot of work with Chestnut and the work that you all do over there around evidence-based practice, training, and dissemination. Because RAND is a research organization, we don't do any of those sorts of clinical or service-oriented activities. And so you bring the right people in to ask the right questions, answer the right questions, and generate the most useful and informative evidence. So, yeah, I'm often partnering with people broadly and diversely, both within and outside of RAND. And I really find that flexibility to be valuable in the type of work that I'm doing.
Oh, thank you so much for setting the record straight and demystifying this thing that is RAND. And it must be a really interesting place to work where you can pull in this broad diversity of expertise.
Yes, that's something that I've appreciated a lot, and it's let me continue expanding my skill set, both in the work that we do and also the ways that we disseminate. So we do publish research reports and journal articles and sort of all the things that you would see researchers at academic institutions doing. And we're also able to create infographics and policy briefs and other types of explainers where you're really just matching the message and the format to the audience that you're trying to reach.
Yeah, yeah. I mentioned in the intro that you have this rare combination of mental health services and economic evaluation expertise. How does this dual lens apply specifically to adolescent mental health and substance use?
Yeah, it's a great question. And I'm going to answer by explaining how I came to have this expertise in the first place. And this is a chance to shout out my PhD advisor, Chuck Bordoon at the University of Missouri. So I came in to graduate school in 2010. And like I was explaining before, I had all these questions about how do we bridge research to practice. One thing I knew about Chuck is that he was an intervention developer and researcher, and that he did quite a lot of dissemination. He had founded his own company on the side that was dedicated to training and dissemination of a treatment model called multisystemic therapy. And so I came in and sort of was telling him, I'm really interested in that. And he said, that's great. I'm not an implementation scientist. In 2010, it was sort of like that was a thing that people were starting to hear about, but it really wasn't a big field yet. But his perspective was, the most common questions we get about barriers and challenges with implementing multisystemic therapy have to do with how much it costs. And so if you want to do something that is practice relevant and could really inform implementation, let's do an economic evaluation. And I was, a brand new graduate student in clinical psychology. And I was like, sure, how hard could that be? And then I went and learned how to do economic evaluation, not in a health economics or public policy program or anything like that, where people would normally learn that method. I was really lucky that at the University of Missouri, you had to have someone from outside of your department on your committee. And so we did a cost-benefit analysis of a clinical trial of multisystemic therapy as my master's thesis. And I got a lot of support from my outside committee member about how to learn and apply these methods. And it's been really useful. This is something that I've been doing now for 16 years. And it is true that people have a lot of questions about why should we be paying more. Evidence-based practices, really for the most part, if you're designing and testing something in research that's going to show improved outcomes, that basically means you're trying to raise the standard of care, right? And so you're almost certainly going to be doing things that are more intensive than what you would typically find in the community. And that's a good benchmark with mental health and substance use services. If you want to demonstrate effectiveness, is you don't want to compare it to nothing. You want to say, does this meaningfully improve outcomes compared to sort of usual services that you would find in the community? So if you want to get better outputs, you're probably going to have more inputs. That's sort of the logic of an economic evaluation. Can you get more value back out than you put in? But there's still a lot of challenges with just because you can show something is cost effective or cost beneficial, who's going to pay for it and how are they going to pay for it? So those same challenges about how do we take these complex psychosocial interventions and implement them within underfunded mental health and substance use systems. That's as true now, or maybe even more true than it was in 2010 when I started this work.
Yeah, but the reality is there are costs associated with all of this work. So while it appears to be rare that you're bringing these two disciplines together, it seems to me that they are naturally or ought to be naturally aligned because outcomes, if you're correlating programs and outcomes, ultimately it comes down to how we can get this funded. What's the quote unquote ROI? So again,
Yeah.
they don't seem to be disparate ideas. So I'm surprised there aren't more people who are actually bringing these two things together.
Right. And it is common. And that's something that'll come up. I have a lot of experience doing systematic literature reviews. And I just did one and was working with, a research assistant and a graduate student here at RAND. And I was sort of warning them when they're screening articles that come up that you're going to find a lot of things that came up as using the terms that we're searching for because they talked about it in the discussion section. And they kind of said at the end, it's really important that we think about how resource intensive or how costly this intervention was. And we should do work in the future to study that. So it's sort of like everybody has that awareness. They always talk about it, but then we had to sort through that and say, well, where are the articles where they actually studied it instead of bringing it up at the end in the discussion section? And that's much harder to find.
Could you, off the cuff, cite any examples, case studies, if you will, where you've applied this model, this methodology to adolescent mental health?
Yeah. Well, when you first said that, I thought this would be easy. And then you added the substance use intervention piece. So,
It's the Catalyst. It's the Catalyst podcast,
exactly.
Alex. Nothing's easy, man. Come on.
Right. And I don't want to misrepresent myself. So I will say I very much started in the youth mental health space, and I came into substance use services later. For any listeners who are not familiar with how siloed these two fields are, even though you would imagine like substance use disorders are part of mental health, wouldn't this all be together? For all sorts of cultural and political and all these other reasons, a lot of what happens in mental health versus substance use is sort of sectioned off from each other. And that's true in research and in practice and in policy. So I came into the substance use space later. And by that time, I had really shifted from studying the economic impact of interventions to studying the economic impact of implementation activities. So the review that I just mentioned that I was working on most recently, we were looking at substance use there, but what we were specifically looking at is implementation strategies that are being used in school settings to implement substance use services. And we looked more broadly at mental health as well. We kind of did that whole umbrella of behavioral health. And thank goodness we did, because an example of the gap here is that we found a lot more research on schools implementing mental health services and very little on schools implementing substance use services. And I should say, we were specifically looking at what strategies they were using to pay for the services, which is a term that I coined in a paper in 2020 called financing strategies. So when I say financing strategies, I mean specifically who's going to pay for implementation and how are they going to pay for it? And that's something that there's almost no research on. So that's why we're looking into it. And again, sort of trying to see what we can learn about substance use specifically. But honestly, the field's sort of wide open there for people to do more research in that area, because we really didn't find much.
Why is there such a disparity between adolescent mental health and substance use programs in schools?
Yeah, that isn't, I'll just give my perspective. This isn't necessarily something that I've studied or written about extensively, but I would say that there's a couple of things going on here. First is that everything on these topic areas is stigmatized, but substance use problems are more stigmatized. People are quicker to move to criticizing and judgment, or an expectation that this person is going to be problematic. There can be more sort of a moral connotation of substance use problems. And there's a lot of societal and cultural messaging that we have around substance use that contributes to that. So anytime you have stigma on a topic, it shows up in all sorts of ways, including how much funding you can get to study that topic and how easy it is to publish your findings and things like that. I think with youth specifically, and especially if you think about contexts of schools, where schools are, at least in the United States, the most common place for our youth to get access to behavioral health services. They're much more likely to get it there than they are to get it in a specialty mental health setting or even someplace like primary care. But that's not the stated function of schools, right? The stated function of schools is to provide education. And so there's always this challenging dynamic about how far do we go when it comes to providing these other services and sort of taking care of the whole child. And so when something is stigmatized, and on top of that, for youth, all substance use is illegal, even if we're talking about alcohol or cigarettes or cannabis. It's all illegal, right? So now at this point, you don't only have sort of resource issues and time issues and all of that, but you're also getting into legal issues when you start asking kids about their substance use and providing some response that doesn't involve law enforcement, which is not necessarily going to promote better outcomes for the youth.
Yeah, I think it kind of, as you think about it, in addition to what you're saying, is that particularly in a school environment, it's probably less likely to see instances or even manifestations of substance use, and it's more likely in the context of a school you're going to see some evidence of some mental health challenges and so forth. And I'm also assuming that, and I don't know this for sure, but mental health issues present in a much broader way, and or just many more people are, perhaps the word is not susceptible, but I'm going to use that word, to having some sort of mental health issue where substance use is maybe, it's not technically a subset of it, but is more narrowly applicable.
Well, that's complicated because all of these conditions they do tend to start showing up in adolescence in particular, sometimes earlier in childhood too. But adolescence in particular, you'll see early manifestations of both mental health and substance use disorders. And sometimes those things are directly
In the context of the
related
school.
with each other. Yeah. And so, you spend a lot of their waking hours at school. So whatever's going on with them, it often does show up at school. I think because of this combination of stigma, is it in scope for us, and the legal issues, there's a lot of incentives to say we should make this someone else's responsibility to respond to the substance use, even if we're the setting where it's first getting detected. And I can understand that perspective, and in different environments and different communities, what that response looks like to be most appropriate maybe does need to be different. That's part of why I describe the implementation process as this active process of making decisions about, okay, what makes the most sense for our community with the resources and the barriers and the opportunities that we have. And if there's some changes we need to make to get that best possible outcome in what our services look like and the highest level of research-backed programs that we can be providing, what is that change process going to be to help us get where we want to go and close that gap?
Alex, what's one upstream financing strategy you've studied that's shown real promise for getting evidence-based treatments for kids adopted more widely?
This is very tricky because, like I mentioned earlier, there's almost no research on which financing strategies are actually helpful. I would say implementation work in general tends to be not tracked very closely and not thought about very intentionally. And so the single strongest recommendation I can make based on what I've seen studying this, like I mentioned, I first published on this concept in 2020. So been thinking about this for a while now, but we're still at the early stages as far as learning. But the things that I've seen that appear to have the most promise are things that are really intentionally paying for implementation. So there's a study that I'm working on right now, actually with Chestnut, and we've been looking at states that were received federal grants to implement the adolescent community reinforcement approach, or ACRA. So that's one of the models that Chestnut developed and disseminates. And we looked at 19 different states and used a method called comparative case studies, where we compared and contrasted the experiences of these 19 different states. And one thing that was really surprising was to see that a lot of these states had pursued getting a higher reimbursement rate from insurance for ACRA. And the argument is, if you get a higher rate, then you can cover some of the additional costs, like I was referring to earlier, of investing in an ACRA program and basically trying to raise the standard of care as far as the substance use services that you're providing. Some states pursued these higher reimbursement rates and got them. Other states pursued these and were not successful in getting any sort of increased rate established for ACRA. That difference did not have any explanation on whether the state was successful in sustaining ACRA long-term after the grant ended. What was helpful was when states found other funding sources besides the insurance reimbursement, which is always going to be tied to you providing a service. And they said, hey, in addition to paying for the service, here's this other pot of money that you can draw from to pay specifically for implementation activities. So things like regularly sending your new clinicians when they get hired to ACRA training and have them go through the whole process that Chestnut provides to get certified in ACRA. That takes a lot of time, and there's a large cost to the organization when you as a clinician are spending time on things that are not billable, because you're not providing services. So having another source to draw from to say, hey, it's valuable to spend time learning this model and learning to deliver it well, learning to deliver it to Chestnut standard and get that certification that designates Chestnut says, I can deliver this model fully as intended. That's a lot of work that is all meant to support high quality delivery and strong outcomes for youth. And so states that said things like that, things like having dedicated supervision for ACRA available within your organization, really just to have a robust program. We're going to pay for that too. And we're not going to do it in this indirect way of just saying, oh, you get paid more to do ACRA. We're actually specifically going to pay for those activities. That seems to make a big difference versus the enhanced rate did not.
Mm-hmm. By the way, who are your Chestnut counterparts in this? We always like to give our people a shout out when we can.
Absolutely. So the main partners on this project have been Mark Godley, Laura Passetti, and Kelly Wright, and lots of other Chestnut folks have been involved over time, but they've been sort of the core three who we've worked with, and they've been fantastic to work with. And as long as we're shouting people out, I will also shout out my colleague Sarah Hunter at RAND, who was collaborating with Chestnut already when I got here, and she was the one who connected us so we could work on this project together. It builds on previous work that she had done with them. And I'll shout out Matthew Lee at New York University, who's leading the comparative case studies. So I'm speaking about a finding that he really developed through doing these compare and contrast of the 19 states.
Talking about this initiative, it seems to me that given funding is so hard to come by these days, that bringing that economic evaluation to these programs is increasingly vital, right? I'm assuming to
Yes.
get these things funded and, to bring that extra rigor to these things.
Yes. And I will say, and I know that the Chestnut folks who I mentioned are aligned with me on this too. Trying to figure out how to get this process paid for is really important, and figuring out how we can streamline the effectiveness of the process and the feasibility of the process of implementation as much as possible is also an important goal, because the more we can do that, the less burdensome it is to figure out that additional funding and what sources it's going to come from, both at the practice level and the state level.
Alex, let me ask you one last question. If you could give one piece of advice to policymakers or system leaders right now to better support evidence-based adolescent mental health services, what would it be?
So, like I mentioned earlier, we have a lot of different dissemination channels here at RAND. And so I'm going to answer this question in a way that is maybe going to sound a little bit like self-promotion, but it's coming from a place of me being like, you don't have to take my word for it, right? I'm not a policymaker. I'm not a system leader. So I'm maybe not the most credible source. But what we've done is, in partnership with people who are in those roles, we have developed, and when I say we, I'm talking about this same project that I've been working on with Chestnut. We've developed some dissemination products that are specifically designed with policymakers and system leaders in mind. And I'll talk about those. They're freely available on the RAND website under my list of publications. And I can also give you the links if that's something that you're able to put for listeners to click on directly. So I'll mention 2 reports that we produced. One of them is a conference proceeding where Laura Passetti and I brought together and facilitated a conversation with folks who work nationally with governors, with state legislatures, and with state Medicaid leaders, and had a conversation with them about what the opportunities and challenges are around scaling up youth substance use services at the system level in a variety of different state contexts. And so you can get a lot of advice directly from them, from reading the summary of the discussion that we had. And I think there's a lot of timely advice in there. For example, them talking about what opportunities states are looking at in a policy environment where, for example, the total amount of Medicaid funding is being rolled back. And so there are certainly provider organizations out there where Medicaid is a very important source of funding. So how they can think creatively about how to pivot or supplement new funding streams to maintain some of those core services, and especially things like evidence-based practices. We know from our work how challenging it is to sustain these practices. So that would be one example of a place where people can get advice. And then we also have a report where we did focus groups with state and federal policymakers talking about their recommendations for federal grants to implement evidence-based practices. This is something that the federal government will do, often with a focus on initial implementation, right? Those grants that I mentioned earlier that were given to states to scale up ACRA are one example of this type of grant. And we compiled the themes of all the different recommendations that these focus group participants had about how those investments could be strengthened. And we also went out and we found applied examples of real-world funding initiatives that had done a good job of enacting those recommendations already. And I think one really neat thing about that is a lot of those examples, some of them were federal, some of them were state, some of them were actually county level. So even though our initial focus for the project was on federal funding, these are processes that can happen at other levels too. So I don't want people to sort of think, oh, well, this doesn't matter unless we have capacity or unless we see the federal government offering funding in our particular area. It's also something that you can look for at state and local levels, and the decision makers at state and local levels, if they're deciding how are we going to make the strongest investment in implementing evidence-based practices, these are recommendations that they can follow and that they can look at for guidance. And I think those participants were really thoughtful. Just to give you one example, one of the issues that they talked about is when you're offering funding to implement evidence-based practices, what counts as evidence-based? And how do you balance being rigorous enough in your definition that you're implementing things that are the most likely to have impact in the community, but also not do it in a restrictive way that is maybe going to exclude groups that are not as well represented in research? And there's communities where they really have their own community-defined evidence that shows what works and that's what they're interested in implementing. And there are ways to sort of think about research evidence and these other forms of evidence together in an intentional way to try to implement things that are going to work for everyone. So that's just one example of the types of recommendations that they were making. And again, we have an example of an initiative that people can look at that we found that did a good example of defining this. That level of thoughtfulness, I think, is going to get you much further than sort of just a generic, vague definition of evidence-based practices, or even really just prioritizing like one or two specific practices. I think you can do that too, but you just have to be thoughtful about maybe who does that leave out? Who is this really designed for, and who do we know that it works for?
Anyone listening to this podcast can find the links Alex alluded to in the description below. Alex, I really do appreciate your time. And one of the things I learned, among several things in this podcast, is how siloed evidence-based adolescent mental health and substance use services are. I know I tended to conflate the two. I won't make that mistake again, Alex.
Yeah. And it's, I would love to see it get more integrated over time. But it is important to recognize that with the way that we have things set up now, because if you want to find people in the community who are doing the work right now, providing substance use services, you need to explicitly look for that. And you can't necessarily assume that, oh, here's this organization that's providing youth mental health services. Are they the most likely place to implement a model like ACRA? Are they the most likely place that maybe is already doing that or is open to doing that? Not necessarily. And you might want to look for, okay, well, who's providing substance use services right now? Who has that expertise? And also who has that trust in the community? Who would be seen as a trusted and safe place to go talk about something that is stigmatized and vulnerable, like your substance use?
Yeah, excellent points. Alex, I really do appreciate you taking the time with me today.
Yeah, thanks for having me. This was wonderful.
Today, I spoke with Alex Dopp, senior behavioral social scientist with RAND. He joined me today from his office in Los Angeles. To learn more about Chestnut or subscribe to the Catalyst Substack newsletter, visit chestnut.org. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.